Shaikh Neesba is going to give you all a brief description about what patient complication is all about during dialysis. So what is patient complication? Let us first check what is patient complications. Patient complications mainly comprises of two words, that is patient and complication. Patient is the person who is getting a particular treatment, and complications are what are the symptoms that are seen during a particular treatment by a patient. So what is this in short is that during a treatment, a patient will show a new disease with the previously existing disease. In cases of cancer, if a patient is going for an oncotherapy, chemotherapy, then the patient, that is a previously existing disease, that cancer is an existing disease, and if the patient is showing alopecia, then that is a new disease which is developed into the patient with the help of that treatment. Similarly, in case of dialysis, a patient is getting treated for a renal replacement, that is dialyzed. The patient is getting dialyzed, and with dialysis the patient will show new diseases. So those new diseases we'll further see what are they. So our main objective is to review the causes and how to treat the complications during HD. Okay, so what are the different types of complications that are commonly seen in patients during hemodialysis? That is circuit related, dialysis related, and patient related. Patient related is broadly classified into acute complications and long-term complications. Further we go on circuit related complications. So circuit related complications, there are many. Among them, air in blood chamber. The blood chambers, you all know that there are two types of blood chambers, arterial blood chamber and venous blood chamber. So these chambers may get air due to flow issues or flushing with no saline. So there is no saline in that air chamber, so because of that because of that also there is air present in those chambers which may go inside the patient and is very harmful. So how we will manage it? We will aspirate the air to the monitor line. The two monitor lines that are present in the near the chambers is used to aspirate the blood chamber through those monitor lines. And in case if flushing is not done, so we have to adjust the needle or the catheter if there is a flow issue. Okay, so the next is air embolism. Air embolism is caused due to bubble which enters inside the patient's body during cannulation. How we will manage this problem is that we will place the patient on its left hand side, that the patient have to sleep on the left hand side, so that the air will travel not towards the heart but it will be away from the heart. 100% oxygen will be administered to the patient, and check of pulse will be taken through pulse oximeter, and we will stop the blood pump so that no further blood goes out of the body and no further blood will come inside the body. The circuit will be given into a recirculation mode. Blood loss. So blood loss is mainly because of bleeding or clot in the extracorporeal circuit or blood retention during termination. How we will manage bleeding? Bleeding can be stopped by applying pressure during the end of dialysis in dressing time, and blood retention during termination is the complete blood of return from the extracorporeal circuit, that is the blood tubings and the dialyzer. Complete blood should be returned, and clot we can't help it, because if the clot will go inside the patient's body, then it may cause harmful issues to the patient. Access recirculation. Access recirculation is caused due to interchanging of the catheter lumen, that is the arterial lumen and the venous lumen. So the catheter inside the catheter is designed in such a way that the tip of the catheter is the venous point, and the holes that are present on the pipe of the catheter, those are arterial points. So if interchanging is done, then these points would be same, but the blood which is entering inside the patient will and going outside the patient will be interchanged. Okay, and needles too close to the veins. So needles will be, if the needle is touching the wall, or if the needle are both close to each other. So then also there is accessory circulation, like the venous blood will go again inside the arterial point again in the same direction. So because of this also there may be accessory circulation. How we will manage? We have to avoid interchanging of the catheter lumens. Some people try it because there may be any flow issue, but to stop this flow issue, we can use another method such as use of urokinase or soda bicarb also. And in case of fistula, we have to keep minimum 2 inches gap between the two needles, and the needles should be in different direction. Understood? Next, moving on is clotting. It may be caused because of heparin free dialysis or natural tendency of the patient body. How we will manage? Timely flushing with normal saline. Alarms should be set in the machine so that flushing, if there is a heparin free dialysis. When do we do a heparin free dialysis? If a patient is having is having a heart ailment, or a patient is on certain medications such as which are used as a blood thinner, or a patient may be just operated. Okay, so then heparin free dialysis are administered. So timely flushing should be given, and if a patient's body is having a natural tendency of clotting blood, so heparin free dialysis is given. Next is poor blood flow. It may be because of needles touching the wall. It may be in cases of diabetic patient, low BP or fistula issues. How we will manage? We have if the needle is touching the wall, then we have to adjust the needle. If the patient is having low BP, then saline should be administered. Patient's UF rate should be lowered. Proper sodium profiling should be given, and dialysis temperature should be lowered, and head low of the patient, and you have to consult the doctor further. Next, moving on is dialysis related complications. Dialysis related complications are seen in seen when there are contaminants present inside the dialysis. Dialysis is the water that is supplied to the patient for dialysis to happen. So if they contain contaminant, the patient may show different kinds of effects with that water. So the most commonly seen dialysis related complications are hyperkalemia. Okay, hyperkalemia is what? More amount of, that is a high amount of calcium present in the dialysate solution. So it may be because of exposure of high level of calcium. So the patient will immediately show bone pains, anxiety, depression, confusion, drowsiness, nausea, loss of appetite, constipation, etc. So there is a list of it. So how we will prevent? We have to take every 2 days hardness test to be done. Moving on to the next one is aluminum toxicity. If there is a high level of aluminum inside the dialysate, and if the patient is getting exposed to such high levels of aluminum, then the patient will show dialysis encephalopathy. Encephalopathy is basically a neuropsychiatric disorder which happens due to dialysis. During dialysis, if a patient is on long-term dialysis, or it may be because of aluminum. And next is renal bone disease. If the kidney is not working, then because of these things, the bone will also get weakened. Next is how we will prevent this? By hardness test regularly. Endotoxin infections. Endotoxin are basically kind of bacteria, dead bacteria or live bacteria. So if patient is getting endotoxin infection, it may be because of high levels of bacteria and endotoxins. So the patient will immediately show complications such as chills, fever, septic shock, severe hypotension, nausea, headache. So how we will prevent these things? By weekly or monthly ROH2O culture or hardness test. How these H2O cultures are taken is that from the main supply, before the water going into the machines, the water is taken as a sample. Around 20 ml of sample is taken, and it will be checked, And from different machines, like from any random machine, also the sample would be taken to check if there are endotoxin or bacteria present in the water. Moving on to patient related complications, we have already covered dialysis related complications and circuit related complications. Now patient related complications are acute complications and long term complications. So in acute complications, you will see hypotension, cramp, nausea and vomiting, headache, chest pain, back pain, itching, fevers and chill. You can see the amount of patients that may get from hypotension, and fever and chill is seen in less than 1% of 2% of patients. So hypotension, what is hypotension? It is blood pressure, low blood pressure in which the systolic is 90, less than 90, and diastolic is less than 60. It occurs majorly in most amount of patients. It may be because of during intradialytic, that is during dialysis, if hypotension is seen, it may be results of rapid fluid removal. If fluid is removed rapidly from the body, then the patient will show hypotension. Okay, so such things are done because the patient wants to attain a dry weight. The amount of fluid removed also depends upon the urine output of the patient. So hypotension can be episodic or chronic persistent. Like sometimes it may be seen, but in some patients it is regularly. So what are the causes of hypotension? It may be because of high UF rate, that is a high ultrafiltration rate, low dry weight. Dry weight is always low of the patient, and the patient is not going on that dry weight. Still, the patient is showing hypotension and complications. So we need to increase the dry weight a little bit. Low sodium profiling, high dialysis solution temperature, anemia, acetate buffer, eating or not eating during dialysis, use of antihypertensive medicines, dialyzer reaction or air embolism. So what are the symptoms that will be seen in such patients? It is that dullness, dizziness, lightheadedness, nausea, muscle pains, yawning, restlessness and weakness. How we will manage hypotension? As a technician, we will place the patient with head low position and then administer 100 ml of normal saline. UF rate should be reduced to 0. Sodium should be profiled. If BP is not normalizing, then we have to give further more saline. UF needs to be lowered. Reassess the patient for the dry weight. Okay, use proper sodium profile. If the patient is taking antihypertensive medicines before dialysis, then we have to counsel the patient about taking antihypertensive medicines after dialysis. Do not give any eating things during dialysis. Buffer should be bicarb solution should be used. Extend the dialysis time. If in case of anemia, you have to give the patient any kind of supplement or injections should be administered. Counsel the patient about weight gain. If there is a large amount of weight gain in the patient, then counsel the patient for the weight gain. Muscle cramps. It is seen in almost 90% of the dialysis patient during the end of the dialysis. It may be because it is majorly because of rapid water movement from interstitial into vascular compartment. It is because of low PTH level, that is parathyroid hormone level. Causes, how is it caused? It is because of hypotension, hypovolemia, a high UF rate, use of low sodium dialysis solution. Hypocalcemia is less amount of calcium. Hypomagnesemia is because of less amount of magnesium. Hypokalemia is because of low amount of potassium. How we will treat? If there is hypotension, then we have to give hypertonic solution, that is saline or glucose, but we need to avoid glucose in diabetic patients, and the best thing that can be done is stretching and massaging. Okay. Headache, nausea and vomiting. It occurs rarely in some patients. It may be because of hypotension or hypertension. It doesn't have a specific thing, so it occurs during dialysis or end of the dialysis. So it may be caused because of hypotension or hypertension. Fluid weight gain. if the patient is having a large amount of weight gain, then also a patient may feel headache, nausea or vomiting. Disequilibrium syndrome. Disequilibrium syndrome we will discuss further. Dialyzer reaction. If the dialyzer is new and a patient is allergic to the membrane of the dialyzer, that is the first time used the sterilant which is used, gas sterilant which is used in the dialyzer, that may get reacted to the patient. So patient may show reaction to that sterilant. So what are the treatment we'll see further. Contaminated dialysis solution, RO dysfunctions. Okay, so treatment what we, in case of hypotension, we need to give a proper sodium profiling. If vomiting, then the patient will be given antiemetics, that is medicines that are used to stop vomiting. Aspirin can be used for headache. Decrease dialysis solution if the solution is contaminated, and monitor and complain for infection controls if the RO is not working properly. And if there is a dialyzer reaction, then the dialyzer and the blood tube will be pre-filled with the sterilant which is used. Okay, next is chest pain. It could be associated with hypotension, occurs very rarely. Maybe what are the causes? Angina, air embolism, pericarditis, hemolysis. Hemolysis is breaking of RBCs. Cardiac event, any cardiac event which is going to be occur. Hypersensitive to dialyzer membrane. How we will treat angina? If there is angina, it may be because of potassium, high level of potassium. So potassium binders are administered to such patient. If there is air embolism, then the patient will be given Trendelenburg position. The patient will be placed on the left hand side so that the air bubble will travel towards the right hand side away from the heart. 100% oxygen will be administered. Administration of erythropoietin with the consultation of doctor's prescription. In case of hemolysis, if there is any cardiac event, then return the whole blood, give extra saline, report it to the doctor, as we are technicians. We can't give any other further prescriptions. If hypersensitive to dialyzer membrane, priming should be done with more saline, or the best thing is that it should be pre-filled with sterilant to reduce the chances of first use syndrome. Next, we are moving on to the chronic complications. What are our chronic complications? Anemia, renal dystrophies, osteodystrophies, malnutrition, hemolysis, Steele syndrome, cardiac ailment, dialysis disequilibrium syndrome, accessory circulation, hyperkalemia, aneurysm, pseudoaneurysm. So anemia. Anemia is basically iron deficiency in the blood. So it occurs in almost all dialysis patients. All CKD patients will show anemia. It may be because of due to iron and erythropoietin deficiencies, or it may be because of chronic blood loss. Because in dialysis patient, blood loss is a must. None of the patient will show any amount of blood gaining. Okay, so what is the cause? It may be because of chronic kidney disease. The dialysis patient's kidney is not working, so they may show anemia. Blood loss during termination, bleeding before, during or after dialysis. Treatment, how we will treat this? If anemia level, if hemoglobin level is low in the patient, then blood transfusion should be administered, and erythropoietin injections will be given periodically, and replete iron. The diet should be given, the dietitian will prescribe to have a good amount of iron in your diet. Renal osteodystrophy. It is actually alteration of blood morphology in patient with chronic kidney disease. If a patient is, if a healthy person is having a proper leg, like the bone structures are proper, then if the same healthy person is getting CKD, then the bone morphology, that is the bone shapes, will change, because kidneys are not working to produce calcium and phosphorus. So because of that, the bone morphology will also change. Okay, uh, to actually, the thing is that it may change because of calcium and phosphorus deposition and their products also. So what are the causes? High calcium and phosphorus products, inadequate dialysis, because the high calcium and phosphorus products will get settled on the bone. So with dialysis they can be extracted from the body. Okay, if the patient is not going for dialysis, then those things will start depositing on the bone, altered bone metabolism, that there is no metabolism. Treatment: restriction of phosphorus in diet. The diet should be without phosphorus. In some cases, if phosphorus is more, so phosphate binders are administered. Adequate dialysis: counsel the patient to come for dialysis every time whenever it's their chance. And calcium-free dialysis is also used. Malnutrition: malnutritions are result for poor diet or lack of food. Already CKD patients are given a lot of diet restrictions in water and food, like they don't have to eat this, they don't have to eat that. So because of that also malnutrition is seen in CKD patient. It happens when the intake of nutrients or energy is too high, too low, or poorly balanced. Okay, so what are the causes? Maybe because of old age, cardiac and liver diseases, dietary deficiency, inadequate dialysis, mental health problem, digestive disorder and stomach condition, recovering from a serious illness or condition. Treatment: consult dietitian from a proper diet chart. Adequate dialysis: go for dialysis thrice a week or 4 times a week, but go for dialysis. Adequate protein intake: protein rich food should be taken. Proper medicines should be taken. If there are supplements, so they should also be taken. Steal syndrome. Steal syndrome is a complex that occurs when the arterial supply to one of the side is closed or occluded, resulting in diversion of blood to the other vascular side. In case of AV fistula, this basically happens, most probably it won't happen in catheter, so it is mostly happening in AV fistulas. So what is a steal syndrome? We have, what is AV fistula? First of all, AV fistula is arteriovenous fistula. So artery which flows at the, if like for example, if we take artery flows at the rate of 600 ml per minute. Okay, so if we are giving like a radial artery is getting connected to a vein, so the blood from that radial artery will get diverted into the vein. Okay, so if we are running our machine, our blood pump at 400 with a very good fistula at 400 ml per minute, so the remaining 200 will go further. Okay, fine. So then the remaining 200, but there is no proper supply of blood going to the further limbs. So what we will do? So what will the hand show? The hand may sometime not show any pulse. It may be pale and cold. It may be numb as well. So let's see what happened. What our slide says. So what are the causes? Restricted blood flow, a brachial AV fistula, end-to-end anastomosis. End-to-end means end of an artery and end of an vein. So what are the symptoms? Hand pain worsens during dialysis. The further limb won't have any sense, that is, will become numb. Okay, pale and cold hand, diminished or absence of pulse. The further limb won't have any pulse. If there is a brachial fistula, then the further radial artery won't give any pulse to the body, to the field. Okay, weakness by the patient. Treatment: treat dialysis related infections. Okay, and then we have to close the fistula because the further hand will get damaged. It won't be any use. Dextrose solution in dialysis if patient is feeling weakness. Then cardiac ailment, because of heart attack, pericardium inflation, surgical history. If the patient is having any surgical history, then also patient will show any cardiac ailment. What are the causes? Cardiac surgery or complaint. High potassium levels seen in the patient. UF is high. If UF is high, then also a patient may show cardiac ailments. Improper sodium profiling, improper dialysate solution, air embolism. If there is air inside the patient's body, then also patient will show cardiac ailments. Treatment, how we will treat if there is high amount of potassium in the patient's body, then potassium binders are administered with the doctor's proper prescription. If sodium profiling is not done, do a proper sodium profiling. Reduce the UF. If the UF rate, ultrafiltration rate, is more or on the higher side, then it should be reduced, and guide the patient about weight gain, not to gain so much. 1 liter per day is the guideline which says about this, and proper dialysate solution should be used. Disequilibrium syndrome, it is a neurological sign. It is a neurological problem which basically is associated with aggressive dialysis. What are the causes? Okay, what is disequilibrium syndrome? It is basically, to be in short words, it is first dialysis of a patient. If a healthy person is told that you are going to start with dialysis, but then very next day, then the patient won't feel good. The patient will be thinking that I have to undergo dialysis. So that mentality needs to be changed accordingly. So the patient won't say the technician that 400 flow, full on dialysate flow, and get the needles inside me, I won't feel any pain. So this has to get settled. So first dialysis plays a very important role in CKD patient's life. So what are the causes? More water is removed. So the water should also not be removed at a higher rate. A nil amount, that is none amount of water should be removed from the patient, so that the patient may settle. Altered senses, the senses will feel a bit altered. Restlessness, the patient will feel restless. Sweating, bleeding, infection, aluminum toxicity, septic shocks, and sometimes even a death of the patient. How we treat? Before going on to dialysis, the patient should be properly counseled about what dialysis is all about. Okay, and proper medications and doctor's guidance should be given to the patient. With everything, then only a patient will be taken for dialysis. Access complication. The most commonly used accesses are catheter and fistula. So in case of catheter, if we see redness, pus, discharge, wetness around wetness, or sometimes even bleeding around the site of catheter insertion, then we need to report to the doctor immediately about it and talk about it to the doctor for further investigations. Okay, and in case of fistula, it may be clotting. If the needle is poked, then it may show clotting or skin infections. So what are the treatment? In case of catheter, antibiotics should be administered. Pus or the discharge which is coming out from it, that needs to go for testing, and proper handling and aseptic technique should be used with the catheter insertion site. Okay, and in case of fistula, cold application and thrombophobia. If there is clot inside the needle insertion point, then thrombophobes are used. Aneurysm. Aneurysm is an outward bulging likened to be a bubble or balloon caused by localized abnormal weakened clot on blood vessel wall. This is basically happening due to continuous insertion of needle on that one particular site. Actually, in case of AV fistula, it is on two particular sites. Needles are inserted on 2 points. So the patient gets used to those 2 points, and those 2 points become a spot where patient won't feel any pain after a certain amount of time. So it may be good for patient, but it is harmful for themselves only, because if they are not feeling the pain, there that part becomes bulged up like a balloon. After a n number of repeated cannulation, sometimes it may burst open as well, or sometimes it will give you pain and it needs to be removed by operating it. So what are the causes happens in long-term dialysis? Swelling of the vein on fistula side happens due to repeated cannulation. How we will treat this? We need to change the insertion points of needles. Okay, practice site rotation technique. Different sites should be used. New points should be used for cannulation. Check for clotting. If there is a clot, then that clot needs to be removed. Get it corrected by surgery. Okay, thank you.